All right. Well, good morning, everybody. And this is being recorded. We're going to continue on with our pharmacology lecture. Pardon?
I didn't consent to being recorded. You signed paper.
There's the door. So, as far as our pharmacology, again, we're not going to rush through this. No, we spent both days last week talking about pharmacology. We're going to talk about pharmacology this week as well because I want you to have that good basis of cardiac pharmacology because a good number of you are going to be moving on into the sequence in the fall, and so I want you to be able to know that. So when we're looking, again, this is we're going to finish up today with pharmacology principles, and then Wednesday we will begin with specific cardiac drugs. One of the reasons that I gave you out the PowerPoints is that your test and your quiz questions will be based upon the answers and the information, Matthew, that you find within those PowerPoints. Pharmacology is one of those things is if you have three different pharmacology books, you may find three different sets of dosing or three sets of side effects or whatever whenever you're looking at those. And that's just simply the way medicine is. Medicine is as much of an art as it is a science. One of the things that I try to do in here is that I want to give you the parameters of what I expect you to know, and these pretty much fall along the guidelines of the American Heart Association, which is pretty much the safest route to go. So as you're studying your pharmacology and as you're studying your specific drugs, make sure that you're referring to these PowerPoints because one of the things that we have, Sydney, when we talk about side effects, it's kind of like, well, how many side effects does Dr. Young want me to memorize? Because with some of the, am I boring you? I see you yawning back there. No, I'm picking on Sydney
I
now.
don't think it's talking to me.
Okay, no, I'm not. I'm just joking. I'm just joking. So take a nap if you need to. It'll be okay. It's being recorded. Okay. One of the things is how many side effects do I need to memorize? Because you look at side effects of medicines, Ryan, and we have all these things that are going on that can go wrong. And so what I've done is I've given you a list of the most common side effects, contraindications. But I expect you, Landon, to be expert with the knowledge that I've given you. I want you to memorize that. And so moving forward within your quizzes, and then obviously with your next exam, and most definitely your final exam, be ready for questions that pertain to the information that we've covered in class. Now, obviously, when we get to class on Wednesday, I'm not going to ask you, Bannon, questions about drugs that we haven't covered here. But you may see some questions about pharmacological principles that we will have finished up today. So when we're talking about different types of medications, in particular when we're talking about cardiac medicines, we want to talk about beta receptors and what happens when we either activate or turn off the receptors found on the heart, Claire. So if we have a beta agonist, now agonist means what? Agonist.
That means the other one means to prevent, and the other one is doing something for you.
Yeah, so think of it like this: an antagonist blocks something. Okay, I think the example I used last week was Narcan is an opioid antagonist. It blocks the action of different narcotics. Okay, any narcotic. An agonist, on the other hand, turns that switch on and enhances what's happening. So when we give a beta agonist to someone, basically these are the three things that you're going to see. You're going to see an increase in the heart rate. You're going to see an increase in the contractile force of the heart. So the heart is going to contract harder. And the last thing, Thomas, we're going to see an increase in automaticity. So obviously it's kind of a no-brainer as far as when we're looking at rate, but what would be the ultimate or initial impact of why we would give a beta agonist? So what's going to happen to our cardiac output, Claire, if we give a beta agonist? Yeah, it's going to increase. No, say it like you mean it.
It's gonna increase.
It's going to increase. There you go.
Wouldn't it-
Don't say it's going to
wouldn't it
increase.
depend, though?
It does depend, and it depends on what.
If their heart rate's already really high, then it's not gonna increase the cardiac output, but it may decrease it.
Exactly. So it's much like everything in the world, okay? I like pizza and I like ice cream. Look at me, I like it too much, okay? When we give a beta agonist, both you folks are exactly right. It is going to increase our cardiac output, but if we increase our heart rate and our automaticity to a certain point, such as what we would see in symptomatic SVT, then our cardiac output is going to drop. So you kind of have a fine walk that's going in there.
It drops because like it can't keep up with the pace, so it just diminishes.
Yeah, so
It's not
basically,
filling up enough, right?
say it again.
It's not filling up enough between beats.
And that's called what? Reduction in what? Not afterload. You're close. Preload. Reduction in afterload. Remember, preload refers to volume of blood that's being delivered back to the heart. So when we've got that really fast heartbeat going on, Matthew, we can't get enough blood back to the heart. Afterload refers to the amount of pressure that it has to pump out against. So, Sydney, basically what we're thinking about with after pressure is blood pressure, okay? Or afterload, not after pressure, but afterload as far as when we look in there. Now, one of the things you want to kind of keep in mind is that arteries have receptors for both alpha and beta drugs, okay? The other thing to keep in mind is that, Richard, if I tell you that a medication is an alpha agonist, now there's multiple different places where we will find alpha and beta receptors, but for our purpose in here, what we're looking at for those receptors will be heart, lungs, and arteries. If I tell you that you're going to give an alpha agonist, that's going to tell you that that's going to constrict the heart or constrict the blood vessels, which is going to do what to our afterload? Increase it or decrease it? It's going to increase it because as the vessels constrict, as those arteries constrict, pressure goes up. So the heart has to work harder to get that out. A beta agent or a beta antagonist would cause, it says a beta agent here, that is incorrect, but a beta antagonist would cause vasodilation. Beta antagonists are commonly known as beta blockers. Beta blockers are one of the most common medications that are given to adults over the age of 40 today. Why? Because we have this huge problem with blood pressure, high blood pressure, and so we give a patient a beta blocker to lower the blood pressure. Elizabeth.
Doesn't it when they take beta blockers, it messes with our vital signs too?
Well, it's going to lower your blood pressure. So it's going to lower your blood pressure, but the other thing when you take a beta blocker is it's also going to lower your heart rate. You'll learn more about the beta blockers that you can give as a paramedic in advanced sequence. And again, watch your emails. The announcement for the entrance exam is going to be going out soon. We're still working on dates, but it's going to go out this week. So if you're wanting to move into the advanced sequence, you need, especially if I'm your advisor, you need to see me. If you have trouble getting in touch with your advisor, make an appointment with me and we'll take care of that. So watch that very, very closely. But I digress. So Richard, basically when we give a beta agonist, it's going to cause increase in heart rate, okay? A beta blocker will cause a decrease in heart rate. It'll cause vasodilation.
An agonist or an antagonist?
Antagonist will cause all of the opposite things that will come into play here. Now, here's the thing to kind of keep in mind. Within the lungs have, again, like I said, both alpha and beta receptors. Where do you think, from our perspective, we're really going to be interested in alpha receptors? What part of the lungs? It's kind of a trick question, but really not.
Bronchioles?
You're getting close. You're getting even closer. Remember, what did I say?
Capillaries?
Capillaries, yeah. So remember, capillaries can dilate and constrict, okay? So when we give an alpha medication, it's going to cause constriction of those capillaries. When we give a beta blocker, it's going to cause dilation of those capillaries, and that could have an effect on the diffusionary process of our patient. Alpha agents can also bring about a little bit of bronchoconstriction. So in what particular disease process would we want to be really, really careful about giving an alpha medication to?
Asthma?
Asthma, most definitely. Remember, they already have a problem, Jack, with bronchoconstriction. So we don't want to use that to precipitate an asthma attack that's coming into play there. When we're looking at beta agonists, they can also bring about really, really good bronchodilation, okay? We typically don't give a beta agonist to bring about bronchodilation. There are other better drugs that we can do for that, but it comes into play there. The other thing that you want to kind of keep in mind is that as far as beta receptors go, they can be broken even further down, and in particular into beta 1 and beta 2 receptors, okay? Beta 1 receptors are found in the heart. Beta 2 receptors are found in the lungs.
You have one heart and 2 lungs.
You got one heart, beta 1, and 2 lungs, beta 2. So you want to kind of keep that in mind. When we are given sympathomimetic drugs, Landon, with the word sympathomimetic, what would you expect that to do to our heart? Increase what? And force, okay? So at basic, sympath means sympathetic nervous system. When we activate the sympathetic nervous system, Martina, we're going to see an increase in the heart rate. We're going to see an increase in the contractile force of the heart. So if, Thomas, we give a sympathomimetic, we're going to give a medication that is going to mimic the sympathetic nervous system. The flip side is true as well. When we give a parasympathomimetic, we're going to, it is, trust me, you get into advanced sequence, you will have more words that'll twist your tongue around your teeth. And so when you're giving this, basically a parasympathomimetic, we're mimicking the parasympathetic nervous system, Jack, and we're dropping down the heart rate, we're causing vasodilation, we're reducing the contractile force as far as when we're going with this. So again, when we see this right here, basically sympatholytic means something that's going to block. So we utilize multiple different types of words to mean the same thing. So again, as you look at your, let's do this. So as you look at this word here, sympathetic, lytic means to cut or to remove, and so, or to block, all right? So sympatholytic means that we're going to block the sympathetic nervous system. Parasympatholytic means we're going to block the parasympathetic nervous system that's coming into play here. And basically, these drugs get to those receptor sites first, and once they latch onto the receptor sites, they don't allow anything else to come into play there. Those processes are really, really important for you to understand and to be able to dissect as far as when we're having a conversation about the mechanisms that drug work. Martina, do you have a question?
I think so. When you said antagonizing is like basically preventing something, but we're also stopping the parasympathetic receptors.
Uh-huh.
So you're basically stopping it, even though you're starting something else. And so if you're antagonizing, it's preventing something. So I'm preventing. So why is that not antagonizing?
Good. Why is it not an agonist? I think is what you meant. Okay, so basically, what is its initial action that's going to be? Okay, so let's look at it this way. It's not a cardiac course, but let's talk a little bit about diabetics. Okay, how does glucose get into the cell?
Insulin.
Insulin does what, Devin?
Glucagon locks it.
Yeah, so insulin is a hormone. insulin attaches to the receptor that's on the cell, and it unlocks it, and it makes that receptor site much larger. The glucose molecule is too large to come through the normal sized receptor site within the cell. Without insulin, now we're not getting any glucose that's coming into the cell. So that's what insulin works. It unlocks it, it opens the door wide, so now that can come in. And once it gets in, then the body makes energy from it. So what we're looking at here, that would be an agonistic effect of insulin so that something else can happen. Now, if we're looking at an antagonist, we're looking at, for example, the most common one is going to be your beta blockers, okay? So what's going to happen here is that, Sam, the beta blockers latch on to that receptor site, don't allow the hormones such as adrenaline and norepinephrine, or epinephrine and norepinephrine, to come into the cell, which would raise the heart rate, which would raise the blood pressure, and the resulting action is going to be a lowered blood pressure, lowered heart rate. So that's kind of where we would look at. Okay, good question, very good question. So when we're looking at this, we've already talked about that. And so let's talk about a little bit of drug math. Relax, don't seize out, okay? This is going to be really, really simple, trust me, I'm not a math person, okay? My philosophy is that there's three kinds of people in this world. One that can do math and one that can't, okay? Think about that for just a little while, and you'll laugh at it later on today, okay? When you realize what I just said. So you're ordered to give 21 milligrams of, or 21 grams of amoxicillin, which is an antibiotic, okay? It comes in a bottle that is stored as 2 grams per 17 milliliters. So the question is going to be, Elizabeth, how many milliliters of amoxicillin will you draw up, okay? First thing we got to figure out is how much is ordered. Well, we know at the beginning of our question that 21 grams, I'm sorry, let me get a little, there we go. So we know that 21 grams are ordered. That's how much we're going to give, okay? So as we go through here, what we're going to do is that we're going to put the amount of medicine that is ordered and divide it by how it is packaged, okay? So basically what we would see here is that here's our 21 grams that are ordered, and it comes packaged as 2 grams, and then we're going to multiply it by the volume of fluid that it comes in, okay? When we do this, and we do the simple math, we simply divide 2 into 21, come up with that number, we multiply it by 17, Richard, and the answer is going to be 178.5 milliliters, and we're going to either round that up or round that down, okay? 178 or 179 milliliters is what we're going to need, okay? Now, this is a made-up problem. You're not going to give that much amoxicillin, but I put that out there just so that we could have a little bit of practice. Yes?
Would the rounding not cause like a danger to the patient?
Only in a very few drugs where that you have to be exact, and none of those drugs would be within our scope of practice. So either rounding up to a milliliter or rounding down to a milliliter would not have an adverse effect on your patient, because a lot of other things come into play here. And you bring up a really good point in the fact that this, as far as we don't really know if this is going to be enough, because is the patient going to be like my size, or is the patient going to be like a 22-year-old female who's an athlete that has no body fat and weighs 98 pounds? And so rounding up or down isn't going to have a negative effect on the drugs that we would give. we can, and one of the things that has pleased me to no end, and it's up until just probably the last year, it has driven me crazy, is that we'll spend $50,000 on a cardiac monitor. We'll drop $250,000 on a new ambulance. But ambulances were not carrying IV pumps. And so literally we were going back, I mean, we were staying in the dark days of when I started of Matthew delivering medications by drip. Okay, was that one drip or was that 2 drips? Okay, but now we see more and more EMS agencies putting IV pumps on their ambulances. If you've got an IV pump, you can deliver 178.5 milliliters, so it's very, very exact. Some EMS agencies haven't gone to that yet. You guys are going to be the change for those agencies, and you're going to promote. We got to get a pump because it's just as important. We want to get the right amount as close as we possibly can. And we'll talk about some medications, and one of the reasons why I'm so passionate about making sure that EMS agencies use pump is we give medicines like dopamine, Matthew. If that gets away, our patient can have a stroke. And so, I mean, we can easily go from a patient that has a really low blood pressure to a blood pressure of 220 over 140. And now our patient, we've done something bad for our patient. And so your question about the fraction there, if you're still delivering it by the old-fashioned method of just counting the drops, rounding up or rounding down will be fine. Okay. Other questions? All right, let's try one more. Okay. Dilantin. Okay, Dilantin is a seizure drug. Is 17 micrograms. PO. PO is abbreviation for to be given orally. With this patient, it's going to be going through an NG tube. Dilantin's available as 20 micrograms for every 9 milliliters. How much would you administer? Go ahead and calculate that based on, it's going to be the same formula that we used before. Elizabeth. Well, go ahead and calculate it, and I'll ask you your answers here in just a minute, okay? Okay, got about another 30 seconds. So the first question you want to ask yourself is, how much are we going to give? How much are you giving? 17 what? Yeah, don't get micrograms mixed up with milligrams, or you may wind up giving 1,000 times too much medicine.
That's
Okay,
a bad thing. That's a lot.
that's a bad thing. Okay, 1,000 times too much medicine is not a good thing. You may wind up on the news.
It's only
Okay,
bad. Sorry, Matthew, got to worry about it.
okay.
It would be 7.6.
Okay, hold on. Okay, we'll come to that, all right? So you're going to give 17 mics. You can call it mics if you want to for short, okay? So here's your formula. We're going to take 17 mics divided by 20, and then we're going to multiply that by how much it is in the solution. We can call this a solution on hand, okay? And so say it again, how much you would give?
7.65 or rounded up to 8.
Okay, Elizabeth, what did you have?
I had 10.5, but I flipped the 20 and the 7.
Okay. So the correct answer is going to be here, Richard, 7.65. And we could indeed round that up to 7 or up to 8. Okay, so we would drop 8 milliliters and we would deliver that through the NG tube. It goes through the nose down into the stomach for people that are having problems taking things orally. All right. Claire, you didn't believe me. Now, do you feel better with what you see here?
Yes.
Okay, then prove it. Last one. Your prescription says that you're to give 200 milligrams of ethyl methyl feel good. Okay. You've got an ampule that has 500 milligrams in 4 milliliters. How much do you want to give in milliliters? So don't shout out your number, just do the math. I'll call on you here in just a second. So Landon, what'd you come up with? Oh, okay, still working. Okay, that's fine. Elizabeth? Okay, you came up with 1.6. Anybody get a different number?
I did.
What'd you get?
I got 10.
You got 10. Okay, let's take a look at it. All right, how much do you want to give? We want to give 200 milligrams. How much do you have on hand? You've got 500 milligrams in 4 milliliters. So there's your formula. We're going to take 200, divide it by 500. We're going to multiply it by 4. And what we're going to do is we're going to draw up 1.6 mil of the medication to give for our patient. Okay? Any questions on it? That is as far as we're going to go on your medical math for this class. Okay? Simple, easy, no weight based. We'll probably get into a weight based administration because some of the drugs that we're going to get ready to move into right now are indeed weight based, and so you will need to figure that up. So I'll give you another formula, but I promise, Claire,
Are you talking about the?
I'm not a math person, so it's got to be simple for me. Devin, what were you
Are you
asking?
talking about the milligrams per kilogram?
Yeah, your milligrams per kilogram, grams per kilogram, micrograms per kilogram, anything that's what based on weight. Okay. Any questions? Everybody feel good about this? All right. Give me just a second to change my slide deck. And
Time's up.
What?
yeah. Everybody's got to be a comedian.
I mean, at least the front row.
Okay. Specific pharmacological medicines that you need to know, okay? First one we're going to talk about is aspirin, okay? Aspirin is classified as a platelet aggregation inhibitor. Now, Matthew, that's a big phrase that just simply means it makes the platelets less sticky, okay? Of medications that you're going to give to your MI patient, unless there are contraindications that would eliminate the person from taking that, aspirin is going to be the most important medicine that you can give. Even more important than giving a patient nitroglycerin or some type of pain medicine to relieve the pain. Why do I say that? Basically, what happens with aspirin is that it serves basically 3 purposes, okay? If you'll remember way back to the beginning of class, we talked just a little bit about what causes the precipitating cause of a myocardial infarction. Does anybody remember what that early cause of an MI is?
Clot?
Even before a clot. That's the result of what happens. Richard?
Blood sitting.
That's kind of in with the clot, okay? All right, now,
Oh, like a plaque, sometimes a plaque will break off and then.
it will. That's a later thing. Now, Landon and Jack, we specifically talked about this in 110, not to put you guys on spot, but does anybody remember what the precipitating cause of cardiac disease is?
Oh, there's lots of them, right? Like stress
Basically
and
one.
overeating and.
Starts with an I.
Indigestion. No, that's not.
Say it again. Inflammation. Inflammation is the primary reason. We'll talk more about this a little bit later as we get into the diagnosis and treatment of patients that are having MIs. But here's the thing to keep in mind, guys, is that, and this pertains directly to aspirin, basically we get an inflammatory process. Inflammation can be caused by a lot of things: stress, pollution, our diet, anxiety, anything. High blood pressure comes along. inflammation normally, let me back up. The lining of the arteries are normally slick like Teflon. Nothing sticks to them. So the blood just kind of flows through, okay? There's no chance for it to stick to the walls of the arteries and develop clots until inflammation comes into play. And inflammation is kind of like there's a teeny tiny little man in your arteries. And he's got this piece of sandpaper and he's roughening up the walls of the arteries. That's where now we begin to get blood that attaches to the wall because of increased friction. It embeds itself in the wall. A clot begins to form. Eventually what will happen is that it'll break off part of that clot, or sometimes, Matthew, the clot will pull the lining of the artery away, the inner lining, and now we begin to get blood that forms behind the inner lining. We'll talk about the names of the parts of the artery later on. But what aspirin does is, first of all, it begins to reduce that inflammatory process that's going on during an MI. So that's one really, really good thing. Second thing that aspirin does is it makes the platelets less sticky. That keeps a bad situation from Richard from getting worse. So we take the aspirin in, platelets don't have a tendency to stick together, and so the clot that is causing our patient chest pain that we suspect, maybe we're pretty much confirmed based on what we would see on a 12 lead, that clot doesn't get worse, okay? But wait, there's more. Aspirin is well, let me back up. When you get to the hospital, what they're going to do, if you call a STEMI alert, is again, they're going to meet you in the ER, and if the cath lab is open, the patient's going to go straight to the cath lab. When you get into the cath lab, Sydney, they're going to do a heart cath, and they're going to go in and they're going to look at, one of the first things they'll do is they'll try to inject some medicine to dissolve that clot. Aspirin is as effective at dissolving clots as the first generation of those clot dissolving drugs were back in the 90s, okay? So not only, Claire, do we stop the process from getting worse, but we also begin getting that clot to dissolve. This is so important that hospitals have to be accredited by a non-governmental commission known as Joint Commission. And this is one of the things that they look at really closely is, did your patient get aspirin within 15 minutes of presentation to the hospital? If you want to win friends and influence people within your hospital, be really good about, number one, giving, documenting, and telling in your report that you administered aspirin, because they get credit for it too, okay? So this is why when you've identified a patient, again, as long as there are no contraindications, aspirin is going to be the first drug or amongst the first drugs that you're going to give. Richard and then Devin.
So inflammation, would it cause a vasoconstriction or dilation?
Basically, it doesn't cause either one of them, but it negatively impacts the artery's ability to dilate.
Okay.
So it's basically, if you think about it, we go in and we scuff up the lining of the artery, and now it begins to get diseased. In particular, when you get blood that forms or collects behind that, the artery wants to dilate, but it can't.
Okay. So
Dev,
basically
I'm
makes
sorry,
it
go ahead.
rigid- So it basically kind of makes it rigid almost?
It makes it rigid. Yep, you're exactly right. Devin.
So where aspirin is like an antiplatelet, and you said it helps allow like the blood cells to slide past each other more. Wouldn't that have a risk of like sending the clot further down? Because like if part of the cells were attached to the artery and they like slip out, would that cause the clot to go down?
Yep, but here's the thing, okay? And you're going to hear this a lot, especially when you get in advanced sequence, okay? Bill's number one rule. Does anybody, have I shared this with you?
I don't think so.
Treat what's currently killing your patient?
Treat what's going to kill your patient first, okay? Is that a risk? Absolutely. Sure, you're exactly right. But again, when we're giving aspirin, we're probably about 90% sure that our patient is having a heart attack. If we don't do anything, we know that that heart attack has a much greater risk of causing our patient to go into cardiac arrest than the potential of that artery or that clot breaking off and going someplace else. So again, you will hear me say this a lot, Sam. You got to treat what's going to kill your patient first. All right. You weigh the risk versus the benefits, and then you go with that. Very, very good question. Okay. What are the indications? Basically, what we're going to do is that we're going to give this to any patient that has an etiology. Etiology is a word that simply means a cause of ACS, acute coronary syndrome. Okay. Acute coronary syndrome. Other words, our patient is having a heart attack, Bannon, and we're going to administer this aspirin to help to reduce the clotting that's going to go in there. Aspirin will do nothing for chest pain of your patient. That's why we'll start with nitro, and we'll talk about that. And then we can go up to more powerful narcotics if nitro doesn't work, okay? Again, giving aspirin within 3 hours of the onset of chest pain shows a huge decrease in the potential for patients to have a cardiac arrest, okay? So that aspirin is really, really important that you're going to give there. Contraindications. Again, when we are talking and I ask you for contraindications for a medication, please do not put that one on there. Hypersensitivity, that just simply means they're allergic to it. That's a contraindication for every single drug and many foods that people eat today. So if you tell me, if I say give me 2 contraindications to the administration of aspirin and you tell me allergy or hypersensitivity, I'm going to mark that as wrong, okay? Because that's true for everybody. 2 of the things that we're looking at here is ulcer disease. And remember, this is a relative contraindication. Now, Sydney, when I say it's a relative contraindication, what does that mean? Doesn't mean that it's a brother-in-law or a sister-in-law or anything like that. But what is a relative contraindication? And guesses are perfectly acceptable.
Like you said,
Hold on. Your name's not Sydney.
That front row has it.
Boy, don't they though? Richard, help her out.
Would be basically, it depends on the patient. It's not a set in stone contraindication.
Yeah, so anytime you see or you hear me say, Sam, it's a relative contraindication, the 2 words that you started out with, it depends, should come to mind, okay? So if you've got a patient that has ulcer disease and they say, well, I haven't had any problems with it for 6 months, okay? You're going to pop that aspirin for your patient, okay? You're going to give the aspirin, all right? But if they tell you, hey, I was hospitalized a month ago because my ulcers were bleeding, now what you're going to do is you're going to go to a higher authority. You're going to get on the phone or on the radio with your med control, and you're going to talk to your doc, and you're going to tell him or her, hey, I got a patient here that tells me he's got ulcer disease, and he had bleeding ulcers a month ago that he was treated for. I'm looking at my EKG. It's showing that he's having an MI. You want me to give aspirin or not? And what they may say is, yeah, go ahead and give the aspirin because the the benefit outweighs the risk. Or they may tell you to give a reduced dose of aspirin. But again, in that situation, do a consult. Doctors do it all the time. Don't try to figure this stuff out on your own, but do a consult to see what the physician wants you to do. So ulcer disease is a relative contraindication. Jack, I'm sorry, go ahead.
So going with a reduced dose of aspirin, I know, at least on our trucks, we don't carry like a pill cutter.
Okay.
So how would you go about reducing the dose of an aspirin?
You'd have to get creative.
Okay.
You know, maybe what you want to do is pull out your scissors, clean them off with an alcohol prep, and cut them as close to in half. Because typically that's the reduction that would be given, would be a half of a dose of an adult aspirin. Okay, good question. Yes? Ooh, and this is why I like it when people give baby aspirin, because we're going to see in just a minute that your dosing regimen for your patient is going to be 1 adult aspirin or 4 baby aspirin. I like it when agencies carry baby aspirin because if you get into a situation like this, you're exactly right. That baby aspirin can be reduced by a half or by a fourth. And so that's a great plan, Elizabeth.
So what about if they are already prescribed it and they've already taken it, or they have like a really high tolerance to it, you don't carry that?
We'll get to that in just a second because that's a very valid question, okay? The other thing we're going to look at here is if your patient has asthma, a history of asthma. Again, that's a relative contraindication. If your patient is not having an asthma attack at the same time that they're having an MI, okay, give the aspirin because we know what's going to kill them, okay? Their MI is going to have a higher risk of killing them than the fact that potentially they may be having an asthma attack that can be brought on by aspirin, okay? So again, treat what's going to kill your patient first. That doesn't mean that we're not going to watch our patient for a potential asthma attack, but it just simply means that we're going to look at that and we're going to go with the aspirin first.
We can also treat the asthma attack that comes on.
The problem with treating the asthma attack that comes on is that the medicines that we will give, and you'll learn this in your med emergencies class, actually put a greater strain on the heart. So the medicines that we give for asthma can actually make the heart attack worse.
That's right, because oxygen in itself is a vasoconstrictor, isn't it?
Potentially, but I'm thinking about if we give like albuterol, it raises the heart rate, so it increases. Say it again.
If the heart rate's already insanely high, you can't give.
Yeah, so we want to kind of watch that, and that's where this critical thinking that we're teaching you comes into play. Some of the things you want to watch about is a lot of patients are sent. Yes, Claire.
Oh, so what do you do in that scenario with an MI happening and an asthma attack?
Hello, doctor. Here's what I got.
What do I
Okay,
do?
literally, you pick up your phone, you pick up your radio, and you do a consult to find out. I will tell you, almost always the physician will tell you to treat the heart attack. Now they may tell you to withhold the aspirin, and now we're going to go directly into epinephrine. I'm not epinephrine, but nitroglycerin to cause that vasodilation to take place. But again, don't be afraid of phoning a friend, and your ER doc is going to be your friend for pharmacology questions. Good questions, Elizabeth.
So what if you can't give aspirin or nitro? Because I know for certain people they can't take nitro because of other things they've taken.
With all patients, you're going to, again, in that situation, you would need to contact your med control if they can't take both of those. That's going to be the rarest of exceptions. I've never, in my career, I've never had a patient that's been allergic to both of them. Now, that's not to say that there aren't patients out there that do have that. I mean, because there's billions of people in the world today. So yes, you can be allergic to any medicines or combination of medicines. But again, in that situation, you're going to do a consult with med control. Watch giving higher doses. This kind of comes into play here with what you said a while ago of the question about, do we give a patient aspirin if they've already taken it? Okay, and the answer is yes.
It just depends
Okay,
on how much they've taken.
say it again.
It just depends on how much they've taken.
Not really, because here's the thing that we're going to look at. First of all, we find out from the patient, okay, when did you take the aspirin? Okay. Now remember, a normal adult dose for aspirin is 2 tablets of 325 milligrams. Okay. The normal adult dose for aspirin for cardiac regimen that you take every day is typically either going to be 81 milligrams. I'm sorry, but 162 milligrams, a half of an aspirin or 2 baby aspirin, or potentially some patients will take a full aspirin. But they're finding now that the sweet spot for the dose, see me after class. So Basically, what happens here is that your patient, their aspirin may be old and out of date. Okay, they may have thought they took it and they didn't take it. So, giving a patient a second aspirin, if they've only taken, the one tablet, even if it's an adult tablet, not going to be a problem. What we don't want to do is we don't want to go above that 2-tablet dose for our patient.
Okay, so the aspirin we give, and you saying that the asthma might be related when we don't give it to them, right?
It's a relative contraindication.
Okay, and so I'm just trying to get all this.
That's fine.
Okay, so basically information comes from some type of infection or anything because your body basically is pushing the inflammation.
Not necessarily even infection. I mean, just stress will cause inflammation.
And so then that opens up the vessels. Dilates. And then what we do is we reduce it by covering up the receptors. And so that brings in constriction of the vessels.
No, basically what happens is that because of inflammation, the vessels are not able to dilate. Basically, the muscle gets stiff. Arteries are very muscular, okay? And so with inflammation, there's a section of the artery that may be able to dilate a little bit or not even dilate at all. And so what we're trying to do is to reduce the inflammation by giving the aspirin so that it would make it easier for that artery to dilate.
And so the person that normally have asthma, they already have something going on with their bronchus. So does
Yeah.
that have to do with the respiratory as well as?
Oh, absolutely, yeah, because aspirin is a medication that can cause bronchoconstriction and stimulate an asthma attack.
Okay.
Good, all right. Some of the side effects you want to look at in particular either have to do with the GI system or with the respiratory system. Richard.
I was just wondering now, so if the vessels, arteries aren't constricting or able to properly dilate or constrict because of the inflammation, would is nitro actually going to that section do anything for it?
So basically what we're doing is that we're giving a drug that's going to override the ability of it. So it may not dilate enough, but it will dilate some.
Okay.
Yeah, good. So again, basically we're looking at GI and respiratory systems that's coming into play here, okay? Stomach pain potentially could cause some GI bleeding. I'll be honest with you guys, I've never ever had a patient that I've given aspirin to that had bleeding, okay? Never. And so taking an aspirin, especially if a person's got a sensitive stomach, taking it on an empty stomach could cause some pain or discomfort. But again, it's nothing like the pain or discomfort that comes about from dying from an MI, okay? The other thing that comes into play is wheezing, okay? And the wheezing comes about because aspirin can precipitate bronchoconstriction, okay? And bronchoconstriction is what causes the wheezing noise that we're going to see in here. Our dosage is going to be between 160 to 325 milligrams, and that's going to be chewed up. We do not give a person aspirin to swallow. The other thing to keep in mind is that we do not use enteric-coated aspirin. Now, Nate, what is an enteric-coated aspirin? Okay. Sam.
Oh, sorry, I had a question. I don't know the answer.
Okay, hold on just a minute, Richard.
Enteric coated is basically your non-chewable, easy to swallow tablets that have a coating to help not mess up the stomach lining is their main purpose, I believe.
Yeah, basically what happens with enteric-coated aspirin is that when you swallow it, Matthew, it doesn't dissolve in the stomach, okay? It moves into the intestinal tract where we have much fewer nerve endings, and as a result of that, the time for that aspirin to dissolve and get into the system and go to the heart to begin doing what it's supposed to do, reduce inflammation, make the platelets less sticky, and to begin to dissolve that clot, can be extended by as much as 30 minutes to an hour. What we want is we want this medicine, we want this aspirin into the system as soon as we can possibly give it. That's why we give the aspirin to the patient. We tell them to chew it up. Tell them it's going to be bitter, it's going to be nasty, but you've got to chew it up until it's a powder, and then you swallow it. We begin absorption really, really quickly because within the mouth, the mucous membrane are very, very vascular. So we begin picking up that aspirin right away, and keep in mind it's only a short distance from here to here. The rest of the absorption takes place within the stomach, okay? Again, if you're at somebody's, let's say you're at a friend's house and all they have is enteric-coated aspirin, Thomas, would you give it to them? Yeah, you're exactly right. Because you use what you have on hand. Now, in your ambulances, you'll never ever carry enteric-coated aspirin. Why? Because the only reason we give aspirin, we don't give aspirin for pain, we give aspirin for cardiac. But if you're at a friend's house and they begin having signs and symptoms of MI, chest hurts, nausea, vomiting, sweating, and all they've got is enteric-coated aspirin, give them that. Tell them to chew it up and to chew it really, really fine and then swallow it, because you can get that aspirin process beginning here and then here.
Well, I don't understand the low numbers. I understand the maximum dose, but why is it 160 minimum?
Doctors are split on, in the process of an active MI, what is the best dose to give, okay? So American Heart, basically what they're doing is that they're saying, okay, we'll go with both ranges. So those of you that are working EMS right now, what's your protocol called for aspirin?
I'd have to look it up.
324. Okay. What else? Do you know what yours is?
481 mgs.
Okay. So that's one adult dose. Most of the time, the adult dose or the full adult dose, 325, is going to be what you're going to administer. But again, one of the things I'm getting you ready for is, obviously, I want you to be really, really good at your cardiology when you get out and begin practicing, but I also want you to pass your exam on that first attempt. And so you may see this dosing range on your registry exam when you go to take it. And so that's kind of the two-pronged approach that I take as far as teaching that. So, okay, so you're using the state protocols, and it calls for one adult. Richard.
Now, I think you already said this, but if I remember correctly, I worked in pharmacy for almost 4 years. So yeah, for like heart attacks, you can take the EC tablets and you can chew them up. They're just going to taste god-awful, even more so than the non-coated ones.
Yeah, if that's all you got, you go with what you got, okay? But again, on your ambulances, you won't carry the enteric-coated one, okay? Any questions on aspirin?
What's the NV?
Nausea, vomiting?
Okay.
Yeah, N/V is always the abbreviation for nausea, vomiting. Anybody else? All right, let's move on to your next drug, okay? Nitroglycerin. And these are not in any real apparent or in order of importance, okay? It is classified as a nitrate and also as an anti-anginal drug, okay? Basically, it works to stop angina within your patient. How does it work? Well, basically, it is a smooth muscle relaxant. Let's talk a little bit about the artery and the muscle of how it's constructed, okay? So within an artery, you've got 3 layers, okay? You've got the outer layer. They all start with the tunica, and the outer layer is called the tunica adventitia. It is a tough, fibrous layer that typically doesn't move, okay? So when we dilate the arteries, the artery itself doesn't get larger or smaller, just the inside diameter of it, okay? Tunica adventitia is very fibrous. It's protective, okay? Within the middle, okay, we have the tunica media. Now, this is where the muscle is. This is what dilates and constricts, okay? So when it dilates, the internal diameter gets larger. When it constricts, the internal diameter gets smaller, all right? The last part that we're going to look at is the lining of the artery, the inside lining. Remember the part that I said that was really slick, normally nothing sticks to it, and that is known as the tunica intima, all right? Now that I've shared this with you, understand that I want you to memorize these because they're going to be important for you as far as when we are talking about specific types of drugs and things that come along. So basically what happens here is nitroglycerin causes smooth muscle to relax. In other words, what we're going to see here is that the tunica media is going to dilate and get larger, and it's going to allow more blood to come through those arteries, even if there's a blockage, okay? So if we've got a blockage in this particular artery here, and it's blocking off, let's say, 70% of the diameter of the artery, Sydney, and we give our patient nitroglycerin, it's going to dilate, and it may increase the size of the relative size of the inside of that diameter to where now the blockage is no longer blocking 70%, but maybe it's only blocking 50%. So we've increased the size that allows more blood to flow through. As a result of that dilation, that vasodilation, we get increased coronary blood flow that's going into the muscle of the heart, which it needs, and it reduces the workload of the heart, okay? Reduces the workload by giving more oxygen to the heart that is kind of struggling, all right? Our indications for this particular medication is that we give it in two situations. Number one, when we have a patient that is suffering from chest pain that we're not sure, or even if we are sure that it's an MI, but basically it's only going to bring about pain relief if our patient is having angina. Most of the time, not always, but most of the time, Nate, if our patient has an MI and we have 95 to 99% blockage of an artery, even if we give nitro, it's not going to dilate enough to reduce that pain. That's why nitro is a really good diagnostic tool. If you're looking at a patient, you've run your 12 lead, your 12 leads show some things you go, I'm not exactly sure, but you give your patient a nitro and the pain doesn't go away, Matthew. That kind of swings the pendulum over more so that our patient is having an MI as opposed to having angina, okay? The other thing that comes about here is that, and we'll learn more about this specific part in 310, which is advanced cardiology. Basically what you're going to do is you want to give it to a patient that's in congestive heart failure, or the term now is just to drop it off. So if you see the phrase heart failure, understand it's the same as congestive heart failure. Old terminology is hard for me to let go because I've used it for well over 40 years. But heart failure is the same thing as congestive heart failure. Basically what it does is it causes vasodilation of the vascular system, and it pulls some of that fluid that we see from patients with heart failure out of the lungs, okay? Contraindications. We don't give our patient nitroglycerin if their blood pressure is too low or too high as a result of increased intracranial pressure, okay? The parameter that we're going to administer nitro is that our patient has to have a systolic blood pressure of at least 100. Richard.
How would I know if they had increased intracranial pressure? Would that be something like
Cushing's drug.
ocular blood vessels or something?
What you just said, Cushing's triad, and the big thing, and we're going to come to that right after the hypotension.
You said at least a what?
Systolic blood pressure.
Systolic blood pressure of 100 or higher. 100 or higher. Okay?
Isn't Christian's triad like a late sign though, or does it happen?
No, it happens pretty early.
Okay, I didn't know.
Yeah.
I knew of it. I just didn't know how fast it.
And the big thing that we're going to look at here with these patients that have potential for increased intracranial pressure is we're mostly worried about patients who have head injuries. Now, so you're kind of thinking, well, how that would come about? You know, sometimes you will have patients that will have MIs or angina, and they'll drive themselves to the hospital, which is a terrible thing to do. Okay, and on the way they have a syncopal episode, they crash, and they wind up now having an MI and a head injury. Okay. And so the big thing that we're looking at with knowing about increased intracranial pressure is going to be their blood pressure is going to go way up, like 220 over 140, way up. When we dilate the blood vessels, understand we're not just dilating blood vessels in the heart, we're dilating arteries body wide. And so one of the things that happens is that the arteries in the brain also dilate. Now think about this, Thomas. The brain is like a sponge, and it's in an enclosed vault called the skull. There's only one little opening in it. That's where the brain stem comes out of the back of the brain to form the spinal cord. If we dilate those blood vessels, that's going to increase the pressure in the brain. The vessels are getting larger, and now what's happening is it's pushing against the brain itself. That's going to make that intracranial pressure even worse. Okay, so it's contraindicated in patients who have head injuries. I've never had that situation, but they have to put that in there. More than likely, what you're going to be more worried about is patients who have a low blood pressure. Now, let me tell you one thing about administration of nitro, and a thing that is really important. Get your IV started first before you give nitro. You know what I'm talking about. You're an experienced provider.
Me and my paramedic talked about this.
Yeah, get your IV started first, because one of the things that happens is that your patient's blood pressure will often drop.
Right, so your IV is there to not counteract that, so balance it out.
Well, there's a couple reasons. Number one is that if the blood pressure drops, it's dropping because we've got really severe vasodilation going on, and we can run fluid through it to raise that pressure back up. But the other thing is, keep in mind that it is much easier to start an IV on your patient when your blood pressure is 130 over 90 than when it is 80 over 60. Okay? Get your IV started first. Use the largest needle that you can. An 18 should be your minimum, okay? Probably not going to need a 16, but an 18 will be sufficient to put fluid in there. But they probably not going to need a 14 or a 16. Let's don't punish our patients unnecessarily. But we want at least an 18. If you can only get a 20 or a 22 in, then you go with what you can get, okay? But get that IV started first, all right? When we're looking at this, some of the precautions, let your patient kind of know what some of the side effects are going to be, and we'll talk about those in just a second. When a person uses nitro for a long period of time, they build up a tolerance to it. Now, we talked about tolerance. What does that mean? Elizabeth?
That it's no longer helping the body and you have to take a higher dose.
Yeah. Yeah, you're exactly right. Good job. So basically, the body gets used to it, and you got to give a higher dose. Martina?
Is it kind of like you get more receptors for it?
Now, basically, the receptors just get used to what is happening. So what you have to do is you have to give an increased dose. Now, we're not going to increase that dose, but just kind of keep that in the back of your mind. Your patient's most likely going to have a headache, and sometimes they will report of a burning under the tongue because we're going to give it sublingual. If you give a tablet, tell your patient not to swallow it because it'll get inactivated for the acid in the patient's stomach. So either a spray or a tablet goes under the tongue jack for it to be dissolved. Nitro is very unstable. That's why if you look at a nitro bottle, if you've ever seen it, it's in a brown colored bottle. So it deteriorates with light and with heat. Okay, light and heat. So tablets can be less effective. And again, you don't want to leave your nitro outside a lot for those particular reasons. Richard?
If you're still at their home, after giving the nitro and it's fully dissolved, would you give them water or something?
No, we're not going to give our patients anything by mouth because we don't know. These patients may be going to surgery, and anything that goes in can come back up and pose an airway hazard. Okay. So our patients are always going to be NPO, with the exception of diabetic patients that we've got blood sugar up, and we're going to feed them. Okay, so you'll learn more about that in med emergencies. Here's side effects, okay? Most common is going to be a headache. Most of the time, patients who have their own nitro are fully aware of this. But let your patients know, okay, you may have a headache. You may feel dizzy. Again, that dizziness or that weakness comes about because we've dropped their blood pressure, okay? So we have less blood going to the brain, and the patient gets a little bit dizzy. But the most common one is going to be a headache. Any medicine that you give your patient, before you give it, let them know, here's what you may feel. So that when they begin to feel it, they have confidence in you that, hey, Paramedic Sam knows what he's talking about. He told me I was going to get a headache. Yeah, I got a headache. That's coming from the med. As versus if we don't tell them what's going to happen, they may think, man, now not only am I having a heart attack, I'm having a stroke as well, okay? When we're looking at this, keep in mind that alcohol can intensify the hypotensive effect of your medicine, okay? It can drop the blood pressure even more. Same way with beta blockers. If your patient is on a beta blocker and you give nitro, blood pressure may drop even more. Elizabeth?
I remember Pfeiffer also saying that you can't give nitro if they've taken Viagra.
But yeah, Viagra or any of the ED drugs is also a relative contraindication. Generally, what we're looking at here is if your patient has taken any ED drug within the last 12 hours, that's going to be pretty much an absolute contraindication. 12 to 24 hours or longer is going to be a relative contraindication. Again, telephone, radio to the ER, talk to the doc, okay? He or she may order you to give the nitro. They may say, okay, give one dose and transport, or they may say just hold the nitro altogether. We can give up to, and I don't have this on the slide, but we can give up to, okay, here's your dosing. Each dose is 0.4 milligrams, whether it's a spray or a tablet. We can give up to 3 doses, 5 minutes apart, as long as prior to giving a subsequent dose, we check their blood pressure, and their blood pressure is 100 or higher, okay? And that, ladies and gentlemen, is where we're going to stop for today. Any questions that you have for me? Let me put a marker in here.
What's the half-life for aspirin?
That's a good question. I don't know. We'll discuss half-lives more when we get into the advanced sequence. We'll especially talk about a half-life of amiodarone and adenosine because one has an incredibly short half-life, like 10 seconds. The other has an incredibly long half-life of like 2 weeks.
Is that because one is steroids and one's not?
Neither one of them are steroids. They're both considered to be antiarrhythmic drugs.
Yeah, so why would it stay so long in the?
Just the way it's made. Yep, just the way it's made.
I can't remember the exact number, but I think aspirin is like a couple days.
Yeah, if you'll download, I think I told you guys about Hippocrates. If you'll download Hippocrates, you'll have all of your half-lives right there. So, guys, Go enjoy the day. Spring is getting closer. Ben, come see me. So I need a 5-page, single-spaced report by Wednesday.
Wait, 5 page,
Uh-huh,
single space.
uh-huh.
Okay.
On Wernicke, W-E-R,
Sorry, can you say that again?
Wernicke, W-E-R-N-I-C-K-E, Wernicke dash Korsakoff syndrome, Korsakoff,
Okay.
syndrome.